You will be placed into the conference as a listen-only participant. Enjoy your meeting.
How are you? Good. How are you?
Just a reminder, today's meeting is being recorded.
And then Dr. Leon, you're on as well? All right, I see Catherine, you're on?
Yes, I'm here.
Excellent. And then I think the other unknown caller is me. Okay, wonderful. Well, thank you guys for joining thus far. We'll obviously give it a couple more minutes before we get started. Frank?
Hello?
Hey, it's Jess. How are you?
Oh, hi, Jess. Jess, how you doing?
I'm good. Is everything working okay over there technology-wise?
It seems to be.
Okay.
So far, all I see is the participants. I don't see slides or anything at this point.
That's because I just did that now.
Oh, perfect. There it is.
There it is. And look, there you are.
Oh, wow.
All right. All right. I actually didn't ask you this the first time we spoke. Your last name is pronounced Leon?
Mm-hmm.
Okay, perfect. Well, we're just hanging out here waiting for some people to join. Normally people will trickle in for the first 5 to 10 minutes. We probably won't wait a full 10 minutes before we get started, but we'll give people a little bit more time, and then we'll go ahead and get started.
Okay, sounds good.
And then I think I already told you this, but I do have today's webinar being recorded.
Can you say that again? You have...
The webinar is being recorded.
Oh, yeah. Okay.
Hello.
Stefania?
Yeah, it's me.
Hey, how are you?
I'm good. How are you?
Good. Thanks for joining. We're just waiting a couple minutes till more people here no problem. And then we'll get started.
Yeah, no worries.
And then I think somebody joined right before Sukanya that I know is not Catherine or Paige or Frank.
It's Jess.
Oh, hey, how are you?
Good. How are you?
Good, good.
I'm still precepting, so I'm going to put you on mute, okay? But I'm going to listen.
Yes, no problem. All right. A couple of people are experiencing logging in difficulties, so hopefully we'll resolve that.
The March of Dimes helps moms have full-term pregnancies and healthy babies. In communities across the country, we are there for moms, dads, and families with a sick baby. And with generous support from people like you, our researchers are looking for new ways to prevent and treat premature birth and birth defects. If you're thinking of getting pregnant or know someone who is, visit marchofdimes.org for the latest information. Thank you for waiting. Someone will be with you in a moment.
Hey, Paige? Maybe
Nearly
she
4
put us on
million
hold.
babies were born in the United States last year.
Okay.
And the March of Dimes
How did we get on this?
more than 75
Hey,
years of research,
I think
education,
that
vaccines, and breakthroughs. In
I think the page might have.
President Franklin D. Roosevelt founded the March of Dimes to defeat polio. Today, we're continuing our cutting-edge work to find the causes of birth defects and premature birth. Learn more at marchofdimes.org. Please hold. Someone will be with you shortly.
All right.
We're working on the next breakthroughs for babies, but we can't do it without you. Why not get involved today? To volunteer for your local March of Dimes, find the nearest chapter by visiting marchofdimes.org/contact. You also can make a donation on our website. Your support helps more babies start life healthy and strong. Thank you for waiting. Someone will be with you in a moment.
Is anybody else from the March of Dimes? Does anyone know of anybody else on the March of Dimes that's on the line?
A variety of helpful information for women and families before, during, and after pregnancy. Whether you or someone you know is pregnant, thinking about getting pregnant, or just had a baby, you can find helpful answers.
All right. So I just want to let everybody know that I muted everybody except for me. This is Jess Brubaugh and Frank, because I'm not sure whose line that noise was coming from. So that being said, if you would like to talk or you have something to say, in the bottom left-hand corner, you could send a message to everybody in the room. So I apologize for having to mute your lines, and there's a few people who still might not be muted yet, but I just wanted to end the recording so that we could get started. And Steve, I see that you finally joined us, so welcome.
Nearly 4 million babies were born in the United
That's the one.
Oh, it's that. Okay, it's gone.
Yeah.
All right, so Frank, can you hear me?
I can, yes.
Okay, so then I'm going to trust that everybody else can also hear me. And again, if you guys have any questions or you need to, you want to have your voice turned on throughout the webinar, just write in the bottom left-hand corner in the chat notes. And I think I narrowed the sound down to 2 people, and so I tried to turn everybody else's mic on. So hopefully that helps. But thank you all for joining us today for the implicit focus on prenatal and postpartum smoking. We're going to go ahead and get started, and today's webinar is being recorded, so we will send it out after if anybody would like to review anything. First and foremost, just to kind of go through our objectives for the day, we're going to share some recent network updates as well as present implicit ICC Phase 2 smoking data. And then we will review evidence and best practice strategies on prenatal and postpartum smoking and smoking cessation, as well as facilitate any discussion and share best practice strategies. So I'd like to welcome Dr. Frank Leon with us today on the webinar. And Dr. Leon is in charge of comprehensive smoking treatment programs at the University of Pennsylvania. So after we go through some of our network data, he is going to give a presentation on smoking as well as smoking cessation options. And then in addition to Dr. Leon, I'd like to welcome the University of North Carolina to the network. And so in the past month or two, the University of North Carolina has officially become an implicit site. And so the number of dots in the state of North Carolina is growing, which is a really exciting opportunity for them. And it brings us to 19 network members that are part of the implicit network. So we're excited to continue to grow through our Quality Improvement Collaborative. Just some brief updates over the summer. We have had our paper in the Annals of Family Medicine published. And so many people who were involved in the network were authors on that paper. And if you haven't already, I highly encourage you to take the opportunity to review it. In addition to the paper finally being published, we also had 2 submissions accepted for the FMEC conference in October, as well as a submission to NAPCRG, which will happen in November. So we're excited to continue to get the word out about the network, as well as share our model, as well as recent data outcomes. And then just briefly, a couple of quick reminders for the network sites on the call. You should have received a quarterly site update from your network coordinator, so please make sure you follow up and you schedule a 30-minute phone call for the month of September. In addition to that, our in-person network meeting is coming up in October. So we'll meet Friday and Sunday. Oh, that's October 30th, sorry for the typo. And then next week, we will send out our newsletter. So that will include a recording as well as the slides that were used in this webinar, as well as a lot of exciting updates, both internally within the network as well as some national preconception, interconception care initiatives. So just briefly, a reminder of our model. The implicit ITC model is to reportedly screen mothers during while child visits from 0 to 24 months of age for behavioral risks, assess current risks at while child visits 0 to 24 months, reinforce desired behaviors, connect with primary providers or community resources to address risks, collect and analyze data, as well as develop strategies to improve care delivery and patient outcomes. So our model specifically focuses on 4 behavioral risks that affect future birth outcomes: smoking, depression, family planning, and birth spacing, as well as multivitamin or folic acid use. And today we're going to particularly focus on our smoking portion of our model. This is a brief reminder of one of the few reasons that we chose smoking as our a risk factor we would intervene on is that 20% of smokers quit during pregnancy, but 70% who quit will relapse within 6 months postpartum. And so our model is to assess maternal smoking and recommend cessation before the next pregnancy, potentially using the 5 A's: ask, advise, assess, assist, and arrange. Whenever we initially started screening for interconception care during well-child visits, our phase 1 data collection sheet had some more in-depth questions regarding smoking status. So rather than just reporting, are you smoking, yes or no, we had the options of saying smoking not assessed, never smoked, former smoker, previously quit but now smoking again, smoking and never quit, as well as unknown. And in regards to an intervention, we had none, advised to quit, written information provided, referred to another program or provider for assistance with quitting, or a prescription given for tobacco replacement or medication, or unknown. In an effort to kind of simplify data collection as we move to phase 2, we really pared down all of those answer options into, is mother currently smoking, yes or no? And if smoking was an intervention done, may include the 5 A's, yes or no. So as we move forward in looking at the data, we're particularly going to focus on phase 2. And so just to show our network screening rates, as usual, we vary a lot per network site. But a couple things to highlight is that we're following about 3,700 mom-baby dyads, and we've collected data at nearly 10,000 well-child visits. And so as we continue to collect data as well as bring new sites on, our volume is certainly increasing. And of those well-child visits, our ICC screening rate is about 65.9%. So we are reaching women. And through our data set, we're also able to show that at 94% of visits, it is mom bringing the baby to see the doctor, which shows that this is an opportune time to reach mom. The moms that we are reaching report about 69% to be on medical assistance, 32% are Black or African American, 26% are Hispanic, 33% have less than a high school degree or equivalent, and 38% report to have a high school degree or equivalent. And the majority of our moms are young moms. And so this summary of maternal demographics accounts for about 49% of the women. And so we're still missing 51% of maternal demographics. We certainly have the opportunity to improve our data collection measures in regards to maternal demographics. And then jumping right into our smoking data, just looking at the question, is mother smoking, yes or no? At 16.2% of visits, mothers report to still be smoking. And then if smoking was an intervention done, they include the 5 A's. At 81.2% of visits, we report to be given an intervention. And so you may have noticed that we're missing about 50 visits in which we're not entirely sure what happened with an intervention. So we don't know if it occurred or it did not occur. And so in the future, we would hope to see that the number of interventions match the number of positive risks, so another opportunity to improve moving forward. And then looking at our smoking data over time postpartum, what you can see in this chart is mother currently smoking over time. And so we start at the newborn visit and we go all the way out to 24 months. And there's very little variability in the number of women who still report to be smoking. And then looking at it in terms of interventions, again, it typically ranges from about 11 to 25% did not receive an intervention depending on the visit. And so it looks like at the beginning we do a much better job at trying to promote cessation, but as the baby gets older, sometimes we're not reporting that intervention. And I think it's also interesting to look at our data per site. In addition to our screening rates, our smoking rates are also pretty variable across network sites. And so you can see here, I'm not sure if you can make out the different colors, but each color represents one of our network sites, and so our orange network site is UPMC McKeesport, and they show the greatest percent of moms smoking. And then as we go down, this yellow line is UPMC Shadyside, the purple line is Mid-Hudson, the blue line is Lancaster General Hospital, the brown line is Shadyside, and the green line is Mayheck. And so we certainly have the opportunity to learn from one another what we're doing at our site to try to help with gestation. And then looking at the interventions provided, we also see variability in how often we're providing the intervention. And then just taking a look at unique women, looking at a cohort of babies born January 2015 to the present. At any visit, 20.7% of our moms report smoking, and so that 27% could be one mom reporting smoking one time, or it could be one mom reporting smoking at 8 well-child visits. So looking at this cohort, we see that about 20.7% of our moms are still reporting smoking. So then just in summary, we are missing 51% of maternal demographics, although that is an improvement because in February we were missing 70% of maternal demographics. And so thank you to all of the network sites who have made efforts to increase their data collection measures. Women reported to be smoking at 16.2% of visits, and interventions were provided at 81.2% of visits. 20.7% of women with babies born January 2015 to present reported to be smoking, and despite these high intervention rates, we continue to see women reporting smoking up to 2 years postpartum. And so as a network collectively, we certainly have the opportunity to improve. And so with that, I would like to introduce Dr. Frank Leon, who is going to focus a little bit more on smoking as well as smoking cessation in pregnancy and postpartum.
Wow. Thanks so much, Jess, and thank you all to the participants. Before I get started, are there any questions for Jess and her presentation, the statistics? I'll just go ahead and my goal is really to take the group through a little bit of general concepts around tobacco dependence and smoking cessation, and then start a little bit of a discussion around the data concerning treatment during this very special time in a woman's life. If at any point there are questions about anything that we're talking about, I'd be happy to answer the questions as we go on. Jess, I think you still have control of the slides. I wonder if you can forward it for me.
Yes.
So I'm still seeing the title slide. Is there something I should be doing differently?
I offered control to you. Do you see the opportunity to accept it?
Oh, where's that? Oh, here it is. Oh, okay. I got you.
Excellent.
Excellent.
There you go. Now you should be able to move them.
Excellent. Here we go. Okay, sorry, folks. These are my disclosures. I have none. I have some grant support for my salaries, but otherwise have no commercial relationships. The objectives start with the general, end up with the specific, describe the biology of nicotine addiction and how it relates to clinical manifestations that you're likely to see in the office. I want to try and identify general management strategies for patients who use tobacco that's relevant to a clinical healthcare practice, and then describe the safety and efficacy of tobacco pharmacotherapy in pregnant and lactating patients. First, the idea of smoking. There are a couple of important points about smoking that always help me stay grounded in a framework for sort of taking care of these patients long term without really ending up putting too much onus of culpability and fault onto the patients who have a difficult time quitting. So the first idea is that nicotine releases gratification-producing chemicals in the brain. We'll talk about that first. The second idea we're going to talk about is that the addictive properties of nicotine actually relate to the rate of delivery of nicotine to the brain and the pharmacology of the cigarette. We'll talk a little bit about that. And then finally, we're going to talk about how long-term exposure to nicotine produces changes in brain function and structure that are ongoing and long-term and translate into a chronic disease model for control over the effects of a disordered brain biology. I want to introduce you to the mesolimbic system in the brain. This is really the system in the brain, part of the lizard brain, so to speak, that actually ends up controlling a lot of our survival instinct impulses. Under normal circumstances, sensory inputs are coming in from the eyes, ears, nose, and they're filtering up through the midbrain on their way up to the sensory cortical areas of the brain. While they're in the midbrain, there's an area of the midbrain referred to, let's see, I want to put the little arrow here, as the ventral tegmental area of the brain, which is essentially a choke point for all these projections from the sensory organs. And at that choke point, the ventral tegmental area's job is to essentially monitor the sensory inputs to figure out whether or not those sensory inputs are relevant to survival. And relevance to survival can be either positive or negative. So it can be a threat to survival, something that the organism needs to avoid, or it can be something that's adaptive, good for survival, something that the organism should be motivated to move closer to. And from that ventral tegmental area, there are projections to other areas of the brain so that when the VTA picks up on something that is relevant to survival, the rest of the brain is then activated to sort of work together, collaborate to deal with that environmental challenge. Emotion areas of the brain, including the prefrontal cortex, the thalamus, areas of the striatum that are involved in creating the emotional context with against which we respond to our environment. Motivational areas of the brain, including the nucleus accumbens, that generate the internal push, that sort of psychic drive to respond in one direction or the other, move closer or move farther from that environmental stimulus. And then finally, memory areas of the brain, including the hippocampus and the amygdala, where these patterns are laid down long term so that we remember that this particular activity worked out pretty well for us, and we pursue that with a higher degree of probability, whereas activities that worked out poorly for us are not pursued with a higher degree of probability. The funny thing about, let me go back one slide. I forgot to mention that the main neurotransmitter system in the ventral tegmental area is acetylcholine, a cholinergic system. The ventral tegmental area is packed with cholinergic receptors, and those receptors on the VTA are nicotinic, meaning that they have the capacity to be stimulated by an exogenous ligand. So when nicotine makes its way into the blood, and the blood is delivered up to the brain, and that bit of blood that runs through the ventral tegmental area bathes those cells in nicotine, they think they're seeing acetylcholine, and you respond, the survival systems respond to the nicotine by creating a sense of safety, a sense of security, a sense of correctness, a sense of gratification, and wholeness, so to speak. This is really where patients are reporting that they're feeling that sense of relaxation and that sense of comfort, that sense of home, because the survival instinct systems have been saying in response to nicotine, they have been giving the signal that this is a good thing to do, that we should remember this, and this is the kind of thing that's worth pursuing. So now the next question is, how do we get nicotine up to the VTA with some degree of reliability? And that's where the pharmacology of the cigarette actually, as a delivery device, comes into play. It turns out that when you're building a cigarette, the nicotine that exists in the plant in its natural form is in the salt form, all the way over here on the left. It's got this methyl group hanging off the end of it that makes it stable in the plant. But when I'm building the cigarette, I add a few constituents, including ammonia or some other basic compounds like urea, etc. I rely on some heavy metals that are taken up by the plant from the earth, including aluminum, nickel, etc., to catalyze the reaction. And when I burn that tobacco leaf and add heat to that reaction, what happens is the ammonia plucks the methyl group off the side, and the nicotine then that is elaborated in the smoke is in what is referred to as the free base form. So it's really the crack form of nicotine that's coming off the cigarette as a delivery device, and that crack form of nicotine is actually exceedingly important in creating the dominant pharmacologic effect of nicotine through the cigarette. And here's a nice graph that helps us sort of see the relative value, so to speak, of nicotine to the brain depending on the delivery device. The first, I'll call your attention to these closed squares here. These are arterial levels of nicotine produced by a few puffs off of a cigarette, and you see that you start off with relatively low background levels of nicotine, take a few puffs off your cigarette, and there's an immediate and intense rise in concentration in the arterial bolus headed towards the brain. And so the brain sees a 40-fold increase in nicotine concentration virtually instantly. As a comparator, these open squares are meant to represent the arterial levels of nicotine produced by a few puffs off the inhaler, a nicotine inhaler, which we'll discuss in a little more detail in a couple of slides. Suffice it to say that you start off with the same background levels of nicotine. You take a few puffs off the nicotine inhaler, and you have this tiny little peak with a sustained new baseline level. And you'll notice that after 30 minutes with redistribution and second-order kinetics, nicotine levels in the blood actually about the same. But it's really the change in concentration that the brain sees that makes the cigarette such a potent device for delivering impactful nicotine to the ventral tegmental area. It's with that big shift in concentrations that the cells then in the brain are really forced to respond. And they respond in a number of very important and long-standing ways. So cells in the connections between the ventral tegmental area and other parts of the brain are altered in a long-term fashion through changes in arborization pattern. What's the sort of patterns of which connections in the brain are supported, which ones are allowed to die off. These long-term changes include changes in the density of nicotinic receptors in certain cells and within certain areas of the brain, increased sensitivity of the receptor ion channel, so even a single receptor can change its behavior based on past exposure to nicotine. And then changes in gene expression. There are a number of different molecules that each cell produces that helps the cell perform more efficiently the next time it's exposed to nicotine. One of these tiny little molecules, these little peptides, is called delta phos-B. Delta phos-B production is ramped up pretty dramatically in the nucleus of the cell, and delta phos-B is stored along the axons, and this delta phos-B actually improves the signaling transmission within a cell that is then stimulated by nicotine in the future. And so delta phos-B, as well as cyclic AMP and a couple other peptides, confer some level of sort of cellular memory, so to speak, or memory at the cellular level, where once a cell has been activated repeatedly by nicotine, it changes its biology to make it more likely to be activated by nicotine in the future in a sort of prolonged and long-standing way. Because this is really about promoting the efficiency of some connections while diminishing the efficiency of other connections, what ends up happening is the connections between motivational parts of the brain and emotion parts of the brain and memory parts of the brain that push a person closer to smoking are emphasized, and the sort of emotional consequence of trying to relinquish or forego smoking under certain environmental cues, in response to certain environmental cues, becomes amplified. And so what patients really experience is ambivalence. They want to stop smoking logically, but instinctively there's a message that says, I'm not sure this is the right time. So they present to us not exactly ready, willing, or able, even though they're interested and curious, and the words that are coming out of their mouth say yes, they act no. And so what we see are people who are almost universally hesitant about moving forward in one way or the other. There's a nervousness, a low-grade panic that's involved. They say they want change, but then in the next sentence they'll say something that suggests that they don't want a lot of change. And I had a quote once from a respiratory therapist. She said to me, I desperately want to quit smoking. I thought that was kind of poetic in that it really describes the desperation with which patients sometimes really want this to be resolved, but don't want to stop smoking. And that's really what they're struggling with. That defines a compulsive disorder. So if a person is compelled to behave in a way that is maladaptive despite a rational set of reasons to try and change that behavior, that's a compulsive disorder. And that's really the sort of manifestation of addiction. And so when you're thinking about how to address a compulsive disorder in your practice, the model that I always use to help me think about this is really sort of the archetypal compulsive hand washing, right? I would never say to somebody who has a compulsive hand washing disorder, you just need to stop washing your hands, because I know that if I said that, that would elevate their stress, their sort of dissonance, and actually drive them closer to washing their hands to try and resolve that dissonance. And so there has to be a more productive strategy for dealing with that. In general, the strategy for dealing with a compulsive disorder is different than the strategy that we would use for changing a habit. So in the habitual paradigm, the cessation model, we imagine that there's a baseline smoking experience here. Thankfully, we would intervene with the magic words or something along those lines and make a big change with treatment, and then smoking would disappear. The smoking would cease, so to speak, and then the patient would then spend the rest of their life not smoking. But we know that that's not the model of the smoking experience over the course of a lifetime. The observed behaviors are much more complicated than that. People pick up and put down their smoking at various intervals for various durations. This is a chronic disease, relapsing, remitting model. And so if this is a chronic disease, relapsing, remitting model, what we're really aiming for is not cure or like the surgical excision of smoking, but really control over the compulsion to smoke over the course of a lifetime. We're looking to reduce the proportion of time that patients spend in gray and increase the amount of time they spend in white. That's really what we're trying to do, and so we have to be ready to use all of the art of medicine, all of the tricks of that a clinician has in his or her toolbox, along with pharmacotherapy, to gain control, exert control, monitor control, and re-exert control when necessary. That's the idea. So let's talk about the behavioral tricks that make some sense in a clinical setting. The first trick I'd like to introduce you to is based on this notion of decision balance theory. Change is the sum total result of the balance between a patient's intrinsic motivations to change balanced against their intrinsic disincentives to change. And so in a traditional model of medicine, what we've been taught to do is to really try to emphasize the motivation. You know, quitting will be good for you, it will be good for your baby, it will be good for your child as the toddler grows. And we try and really emphasize the motivation, and a lot of times we try and be nice about it and subtle and selfless about it, but always we've been focused on the motivation. The problem is that the mesolimbic system is instinctive, and it's powerful, and it's influential. And so the degree to which patients sometimes feel a disincentive, even if it's difficult for them to articulate where it's coming from, they will feel a disincentive that is larger than any motivation that we can supply for them. And so the balance is off kilter. It's not the traditional balance idea. Really what we're doing when we press down on the motivation side is simply increasing the tension and creating a circumstance where people will likely try to escape and resolve that tension by using nicotine. Instead, many of you will be already familiar with the idea of motivational interviewing. In short, motivational interviewing is the idea where what we're really trying to do is not so much increase motivation directly, but rather increase the relative value of patients' existing motivations by decreasing the disincentives to give it a try, to do something, to move forward. And so really what we're doing there is systematically identifying what the disincentives are and undermining those disincentives. And there are many ways to do that behaviorally. You guys have a lot of experience with this already, but one of the main ways that we're going to talk about dealing with this sort of instinctive disincentive to quit is the appropriate use of pharmacotherapy. Rather than spend a lot of time talking to you about how to do motivational interviewing, for the folks on the call that have never thought about motivational interviewing in the past, the sort of cheater way to think about motivational interviewing as a behavioral mechanism for relieving the disincentives is to spend time basically asking questions instead of giving answers. If you're giving answers, generally speaking, you're talking to this side of the brain. If you're asking questions, you're allowing the patient to express what his or her disincentives are. And just the fact that they're expressing it themselves, they're coming up with the ideas that undermine the value of the disincentives. Just simply making it cognitive and allowing them to say it out loud undermines the relative impact of the disincentives. So practice asking questions instead of giving answers. And then there are some style issues that I tell people to think about. You need to be able to express some level of empathy, join with the patient. It's not an adversarial relationship. It's more of an advocacy relationship. You and I will search for answers to fix this problem. Validation, it makes sense to me that you feel that way based on what I understand about the nature of addiction. And finally, hope, just say basically always looking forward, regardless of what their past experience is, injecting hope into the situation. And so that is the basic behavioral framework for moving people along some continuum of change closer to putting their cigarettes down, regardless of whether they're pregnant, not pregnant, man, woman, young, old, doesn't matter. That's the basic behavioral framework. I'd like to move into sort of the pharmacotherapeutic framework at this point, spend a couple slides talking about pharmacotherapy. We're going to talk a little bit at first about nicotine replacement therapies. This cartoon is really just a graph meant to represent the difference in levels of nicotine produced by the cigarette in red, the patch in green down at the bottom here, 24-hour transdermal delivery device, and other acute forms of nicotine delivery like the gum or a lozenge or inhaler, which are someplace in between these big peaks and these no peaks sorts of delivery. Okay, so that's just a graph, a visual representation of the pharmacokinetics of the different products. And so that drives a strategy for using pharmacotherapy in order to maximize their impact on your patients. So, for example, if you think about medications in terms of relievers versus controllers, the patch is a great example of a controller medication. It's meant to sort of control or minimize the frequency and intensity of those compulsive impulses to smoke. And generally speaking, when you're using a controller medication, the right paradigm is to start high and work your way down rather than start low and go slow. So it's like the asthma model. Get control first and then back off as acceptable as opposed to the other way around. 90% of people who are treated with nicotine replacement products are underdosed, meaning that whatever dose it is that we start them on results in incomplete control of their compulsive symptoms. So don't be afraid to use a 21 milligram patch, regardless of how many cigarettes they use per day. The instructions suggest that we should step down the patch over 8 to 10 weeks. There's a lot of good data that suggests the longer we use the patch, the more effective the patch is at producing long-term control over compulsion. Despite patients' concerns about side effects from the patch, the most common side effect is local irritation, either directly from the nicotine or from the adhesive. Those are easily controlled with, just cleaning off the skin or perhaps a little topical corticosteroid cream, anti-itch cream to try and reduce the irritation. Nicotine also comes in acute delivery forms. The archetypal one is, of course, gum, and gum comes in a couple of different doses. It comes as a 2 and a 4 milligram dose. The idea of the gum is really not to chew it like gum, but rather to use it more like chew tobacco. So you chew it just to get it soft, and then you park it up against the mucosal surface inside the mouth. And the bigger the contact patch, the better the absorption is. So I tell patients really plaster it up against the inside cheek and then just leave it there. Don't move it around. We want a nice big contact patch with a good solid duration of contact. And this here says, this says 1 to 2 pieces per hour when used alone. You can use the nicotine gum either alone or in combination with the patch to relieve acute cue-induced cravings. The inhaler, we talked a little bit about the inhaler earlier. The inhaler is a nice device. It's supremely self-titratable. I hope you can see it. It's basically this hollow plastic tube. It splits in the middle. You put one of these little cartridges on the inside, and then patients can just sort of puff on this as much as they like whenever they have a little taste for the cigarette. Oftentimes patients will report to you that sometimes I just need to take 1 or 2 puffs and then I put the cigarette out. And this is a really nice option for that circumstance. You can give them the opportunity to take a bunch of puffs, and then it sort of turns off the compulsive instinct or the compulsive signaling inside the brain by essentially tricking the brain into thinking that you just smoked a cigarette. This is not an electronic cigarette. There's no fake smoke. There are no flavorants. As a result, you don't really smoke this thing as much as you puff on this thing, more like a cigar. You puff it so that the peppery sensation of the nicotine is felt in the posterior pharynx rather than down in the lungs. Again, you can use this alone or in combination with a patch. Combination strategies really drive up the odds ratio of successful treatment. If you use one nicotine replacement product, you double the likelihood of success. If you use 2, you quadruple the likelihood of success compared to double. So it's like a 7 or 8-fold increase in likelihood of success if you're using more than one nicotine replacement product. Bupropion SR started its life as an antidepressant. It's available generic at this point. The sustained release product is really the only one that was tested in the smoking cessation context. There's no good reason to suspect that the XL, once-a-day dosing would be any different, except for insurance issues and availability and that kind of stuff. But anyway, the target dose is 150 milligrams of the SR twice a day. Usually I tell people to have it one at breakfast, one at dinner, so that they're not taking it at bedtime. It's just like the regular antidepressant effect. It takes about 4 weeks to reach its maximum effectiveness. So you really want to start the bupropion earlier than you anticipate people wanting to put their cigarettes down, and then just sort of waiting for its impact on impulsivity. It helps to control impulsiveness and improve a patient's ability to control their cravings to smoke. And then finally, varenicline is an antagonist of those nicotinic receptors in the ventral tegmental area. Again, really requires about 4 weeks to reach maximum effectiveness. Start the pills early. 1 pill twice a day, usually with food, helps. The main side effect for varenicline is a little bit of nausea when you first start taking it in about 10% of patients. And so having some food on their stomach helps to minimize that effect. Generally speaking, patients expect a miracle with varenicline. They want to take the pill and a week later stop smoking, and if that doesn't happen, they imagine that the pill didn't work. Your most effective advice is, hey, just keep taking the pill. It's going to work. It works at different points, at different rates for different people. Even if you have to renew the first month's prescription, go ahead and do that, because about 30% of people who are going to respond to varenicline will respond after that 4-week refill time frame. Now, specifically around pregnancy, I'll make a couple of points. Obviously, the sort of main concern is really during pregnancy, but also after pregnancy, in between kids. We want to protect mom. We want to protect the next kid. We want to protect the kid that was just born. We want to do a bunch of stuff when we're intervening with tobacco. Just going to remind us that the medications come in lots. There's a lot of different information about exactly what pregnancy category they are. I think the main point about pregnancy categories with these medications is that they are in evolution at this point. Regardless of whether you think about them as A, B, or C, the truth is that smoking is clearly and unambiguously an X, pregnancy category X behavior. And so the decision about whether or not to use medications in this context is not really about whether or not there's an appropriate risk-benefit ratio. There is. It's really about whether or not the specific person in front of you understands the risk-benefit, whether or not those risks can be managed safely, whether or not they're available for follow-up, and those are really the concerns. The theoretical, there is a clear risk-benefit advantage to treating patients, but on an individual basis, that's where the art of medicine comes in, and you have to decide what's best for the patient in front of you. Again, the pregnancy categories are variable and in evolution. A couple of things about nicotine replacement products. Generally speaking, the information is really available about nicotine. There's a little bit of information available about bupropion and very little on varenicline. So we're going to focus on nicotine replacement products predominantly. The idea of treating pregnant women with nicotine replacement products started out in the early 90s, and it was, Neil Benowitz noticed a few things. First of all, fetal morbidity and mortality was associated with internal smoking is dose-related. And it's related to the peak dose. And remember that from the cigarette, the crack form of nicotine creates very, very high peak doses, way higher than you can produce from systemic absorption from gum or patch or anything else. And so plasma nicotine levels that you can achieve by using 2 pieces of 2 milligram gum per hour was only a quarter of the baseline background plasma nicotine levels achieved with continued smoking. There's some maternal heart rate and mean arterial pressure changes that are noticed with smoking that are not noticed, smoking and NRT that are not noticed with placental blood flow. Okay, so fast forward to 2012 or 13, I forget what year this was published. It was a couple of years ago, though. This is a Cochrane collaborative meta-analysis on the use of NRT during pregnancy to help people stop smoking. And unfortunately, there's really only a handful of placebo-controlled trials from which to draw. Most of them only had just a handful of patients. The largest trial available was this Coleman trial from 2012. Essentially, they failed to cross the unity line with any degree of reliability, and so up front, just looking at the sort of pooled data, there's not a lot of signal that nicotine replacement products would be useful. There is, however, some signal in non-placebo controlled trials that nicotine replacement may actually be useful in helping people to control the compulsion to smoke. And so what's the difference? And, if you look at the Coleman trial, was part of this SNAP multi-center trial team. It was published a couple years ago. 1,000, almost 1,100 patients enrolled and randomized to receive either active patch or placebo patch. What they noticed was at the end of the study, cessation rates were really not a whole lot different. It was 12% versus 10%. But at the end of the first month of treatment, there was a statistically significant impact of treating with nicotine replacement. And the difference is that they had, after the first month, only 7% of their participants continued to use the patch. And so I think, the one point that's important about this study is that if all we do is give patches to our pregnant patients and say, we hope this does the trick, we're not really going to actually achieve very much change. But if we can keep them on the patch during their pregnancy, then there's a likelihood that we're going to achieve abstinence rates which are totally in line with the general population of patients, what you would expect the effect size to be from treating a general population of patients. Question then comes in, what's the safety of a strategy like that? And this study actually just came out in the American Journal of Obstetrics and Gynecology just about a month ago. And this is an observational trial. They looked at over 1,000 records on over 1,000 women who were in similar circumstances as the patients that just described earlier within the network. It's an observational trial, so this is really about patients who got prescribed nicotine replacement or bupropion. And both of those had actually a protective effect over continued smoking. The odds of the baby being born prematurely or the odds of them being born with smaller than gestational age were actually much smaller if they were treated with cessation pharmacotherapy than if mom was not treated with cessation pharmacotherapy. Even in the Coleman study that we described earlier, they failed to identify any impact at all on any of the birth characteristics, postnatal complications, any of that stuff in the patients who received active therapy. And then the final question really is, how useful are these medications at preserving abstinence after mom gives birth? That's really the time where a lot of folks, even if they've been successful quitting, they will relapse back to quitting almost immediately after delivery. And so we need a strategy for improving that. And it turns out that, again, it's not so much about whether or not we give them the medications as to what we do with it. If we bring them back in for postnatal visits and actually keep smoking on the problem list and review how are you using the nicotine, I want you to stay on it. Continued use of medication essentially doubles or at least increases the odds of successful abstinence by 50% over strategies that simply focus on the gravid period. As far as lactation is concerned, I know that's a big concern. There's not a lot of data around lactation. There are no reports formally assessing nicotine replacement therapy during the lactation period. We do know that nicotine, just from pharmacology studies, is excreted into breast milk. We don't think that it's absorbed to any great extent in the baby's gut, however. Unfortunately, the American Academy of Pediatrics strongly encourages that we work toward smoking cessation even during lactation, but can't make recommendations for or against nicotine replacement products because the data doesn't exist. Here's another example of where I feel like we know that if mom goes back to smoking, that's going to, during the lactation period, that hurts the baby. We know that. And so the answer is not in some large generalizable statement, is there sufficient evidence, but really the answer comes down to your relationship with the patient and what you assess as the relative, what are the patient level variables? How much do they understand? How reliable are they? Are they going to come back for follow-up? That kind of thing. There's a little bit of data about bupropion. There's no data really about varenicline. I don't think anybody can recommend using varenicline during pregnancy at this point. So I'm going to finish up with just a couple of points to remember. First, it's important to think of smoking as the behavioral manifestation or the cardinal sign of a disturbance in brain biology. It's not simply a behavior like picking your nose or playing with your hair. It really is a manifestation of a disordered brain biology that results in the compulsion to smoke. And that compulsion to smoke almost universally manifests as a reluctance not to smoke. And so we have to get better at dealing with that reluctance. Medications are a good way to help us deal with the reluctance, particularly when it comes to pregnant women. The benefits of cessation during the antepartum period as well as interconception are very large and well accepted, not just on mom. We didn't talk about the impact of environmental tobacco smoke on the baby, but it's pretty profound in terms of developing lung function and risk for future lung disease, et cetera, et cetera. So the risk-benefit ratio is clear to help clearly in favor of helping women stay off of the cigarettes. Staying off of cigarettes really comes down to adherence to pharmacotherapy. Medications work better when you're using them, and adherence to that pharmacotherapy appears to produce cessation rates that are in line with general population effect in terms of both cessation and relapse prevention. And so now we have to think about systems that we have in place to improve adherence with these medications postpartum. Finally, NRT and bupropion appear to pose little risk to the baby in terms of gestational age, et cetera, and appear to actually have a protective effect compared to smoking. I think I'll stop there and ask in the time that we have left, there's only a couple minutes, but I'll ask if there are any questions from the room.
Were you saying that there's a reluctance to quit or a reluctance to smoke, and then once you got over that, there's a reluctance to quit because of the brain biology? I just want to clarify your closing statement.
It's really a reluctance to quit. And so the initiation of smoking happens almost universally during the adolescent or young adult period. And it's during that time where the brain is in a period of rapid turnover, high plasticity.
Okay, so part of it is that. Okay.
Exactly, and exactly right. And so it takes really a very limited exposure to the crack form of nicotine in order to start to make physical changes in the brain. And once those happen, the likelihood that they'll continue to pursue the behavior goes up. Mm-hmm. Once they're in a rhythm, then the big problem is not so much an unawareness of the ill effects of smoking. The bigger problem is some instinctive message that's saying, "Ooh, please don't stop now. Not now. This isn't a good time."
Okay.
Yeah.
Yeah. Okay. I just wanted to clarify that because that's certainly what you hear from people is that they can go through heroin detox, but they can't quit smoking.
Yeah.
So
yeah. Exactly right.
Thank you. It was
Steve,
really helpful.
Ratcliffe
really
here, Frank.
Yeah.
What a terrific boost for us to get our heads around these practical aspects. There's a small number of us at today's webinar, but I would really love when we get together as a network with about 40 of us to perhaps get you over here for an hour or two in person with us in April. But a quick comment, half of our low-income women here lose insurance at 2 months. I just learned 2 days ago the bupropion, which is generic, at Walmart is $80. It's not on the $4 copay. Right. So as expensive as our cigarettes are, so are the medications. We have perhaps opportunities with the DOH grant in Pennsylvania to look at some creative ways to provide some subsidized or available either nicotine replacement or bupropion. But again, thank you very much. You left us with a tremendous amount of things to chew on.
Sure, Steve. My pleasure. Thanks for inviting me. I'll leave you with this last idea. It really is networks like IMPLICIT that then all of a sudden start to have the levers in place that change the insurance environment around tobacco. So, for example, we know that it's an incredibly important problem. We know that we would rather the insurance environment around smoking cessation pharmacotherapy to be different. And, from the insurer's point of view, they look out and they ask, well, how many people really want it? Do they continue it? Is it worth the money, et cetera? There's all these issues. But we as clinicians are in a position to really demand or start to demand stuff and say, you are contributing to this epidemic if you don't rethink your position on paying for these medications. So I know that's a big ask, but it's something really as a network, you have more clout than individual organizations and have the potential maybe to explore changes that are system-wide.
I appreciate your emphasis at the beginning on the motivational interviewing mode. The advantage of our model is that we have, for the most part, continuity with the same woman for 2 years through 6 to 10 visits with their baby and their young child. So I think a model of working on the internal motivation and the agreement to go with some of these agents might take a couple of visits.
Right, exactly right. Yeah, that's an important point. This is not a surgical problem. This is about therapeutic relationships. This is about sort of long-term thinking. This is a chronic disease model. You don't fix type 1 diabetes in one visit. You set the stage and you work on all the associated problems sequentially, and that's exactly what